one of the most challenging disease and rare etiology of cardiopathy, which is cardiac sarcoidosis. And with the title of her presentation today is Cardiac Sarcoidosis, the Evolving Concepts in Diagnosis and Treatment. Without further delay, Prof. Qing, the screen is yours.
Thank you, Dr. Sismaya, for the kind introduction. Dear Chairman, Dr. Sismaya, dear panelists, ladies and gentlemen, it's my privilege, to participate in this international symposium. I'm so glad on behalf of the China Alliance of Heart Failure Center to give this talk and have your invaluable comments and discussion of the panel discussion after the talk. I'm trying to share.
Can you share your screen, Prof. Qing?
Yeah, I'm trying to.
Okay,
Sorry.
no worries.
It takes.
Okay.
I'm sorry.
Yeah.
Just a few minutes. Yeah, it's on. It's on. Can you see it?
I still cannot see your slide, but probably you can just stop share first.
Can you see my slide? Can you see it?
Still cannot. Probably you can stop. Yeah, probably you can stop share first.
Stop share first.
Yeah, stop share first, and then you can
share.
No,
let me try it. Let me try it again. Can you see it?
Still can. Okay, now I can see it clearly. Thank you so much.
You can see it. You can hear me, right?
Yes.
Okay.
Loud and clear.
Wow. Okay. Sarcoidosis, the evolving concepts in diagnosis and treatment. So as Dr. Sismaya said, it's a rare etiology of myocarditis and cardiomyopathy. So sarcoidosis is actually a multi-system granulomatous disease that can occurring at any age, but often between 20 and 60 years. It's characterized by presence of non-casseting granuloma, a cluster of macrophage, epithelial cells, CD4 T cells, and pulmonary involvement occurs in over 90% of sarcoidosis patients, although the sarcoidosis can involve multi-organs all over the body, eye, lymph nodes, and including heart, the cardiac sarcoidosis, that's the topic of our today. Regarding the global prevalence, actually, it occurs in less than 5 cases, from less than 5 cases to more than 50 cases in every 100,000 populations. It's mostly occurs in Africa American individuals, North European countries like Sweden and India. It's an multi-system granulomatous inflammation of unknown etiology. There are some the enhanced interferon gamma expressions by CD4 T cells, and the granulomas located in the heart actually led to the scar fibrosis formation, as distinct patterns can be recognized by biopsies and specific images like CMR and PET-CT that we'll talk about it later. And the symptoms of sarcoidosis actually come from the non-specific symptom of systemic inflammation, like fever, general malaise, like sweats and reduction in the weight, and also the organ-specific signs and symptoms. And like that's showing the busy tables that can affect the skin, eyes, and respiratory system. But what is cardiac sarcoidosis? The cardiac involvement and can occur in sarcoidosis in these following three main ways. It can occur as the non-sarcoid cardiovascular diseases like ischemic heart disease, which shows an increased association in patients with sarcoidosis, occurs more frequently in patients with sarcoidosis. It can be due to the right heart remodeling from pulmonary hypertension, which is predominantly seen due to the progressive lung diseases. But the topic we were talking about today is the direct granuloma formation within the heart, which is termed cardiac sarcoidosis, CS. The symptomatic CS occurs in about 5% of patients with systemic sarcoidosis, and silent, or we call it asymptomatic CS, can occur ranging from 5% to 50% of patients with extra cardiac sarcoidosis, systematic sarcoidosis, and also in 25% of patients by autopsy studies. The average diagnosis is approximately 50 years old. So although it's a CS is a rare disease, but CS is responsible for over 80% of deaths from cardiac sarcoidosis, either due to heart failure or sudden cardiac death that we were talk about it later. And immunosuppressive therapy, mainly the corticosteroid, is expected to solve the symptoms, delay progression of CS. But much remains to be learned about the therapy for cardiac sarcoidosis. Well, the granuloma can infiltrate in any layers of myocardium or in any areas of the heart. Frequently, it's seen in left ventricular free wall, the interventricular septum, and the right ventricular wall, and rarely in left atrium and right atrium. So from the autopsy specimen here, we can see the thinning of the interventricular septum and the bilateral ventricular enlargement, which the thinning is probably due to, due to the fibrosis of the myocardium and in the later stage of the CS. The principal symptoms or clinical features of CS include conduction abnormalities. The third-degree AV block is frequently seen, and ventricular arrhythmia, VT, VF, which is a major cause of sudden death, and heart failure. And the symptoms and the prognosis really depends on the location or extent of the granuloma infiltration, or usually it appears in a patchy infiltration or location of this granuloma formation. The clinical features including the heart failure, it can present as dilated cardiomyopathy, secondary functional mitral regurgitation due to the enlargement of the mitral annulus or infiltration of the papillary muscle. The valvular itself is really is rarely involved, but the papillary muscle infiltrated papillary muscles. Pericardial effusion, template pulmonary hypertension, which is another cause of heart failure. Aborted sudden deaths may syncope or presyncope from ventricular tachy, ventricular fibrillation, and or AV block, thoracic discomfort, paroxytitis, pulmonary hypertension, or very frequently the symptom of palpitation from atrial arrhythmia. So regarding the biomarkers for CS, actually there is no specific for cardiac sarcoidosis. The most serum biomarkers found in CS actually are produced by inflammatory cells involved in granuloma formation. However, serum angiotensin converting enzyme, ACE concentration was found to be elevated in over 60% of patients. It can be regarded as a marker of disease activity and association between cardiofibrosis. And the natriuretic peptides and biomarkers of myocardial injury is useful as screening test in patients suspicious of CS, and in particular in those patients have been already diagnosed as systemic sarcoidosis or extracardiac sarcoidosis. Biomarkers can be also used as index of disease activity and treatment response, but it remains in the study, in the research, not in routine clinical practice. And ECG can be used as a part of the screening tools, and ECG abnormalities is frequently seen in CS patients. More than 90% of patients. Common ECG findings include RBBB, AV block. AV block is most common, occurring in about 50% of CS patients. Ventricular premature beats, ventricular tachy, AFib or flutter in about 30% of cases, and other abnormalities can also seen. Holter can help to detect arrhythmia in response to immunosuppressive therapy, whether the patient is responsive to immunosuppression therapy. And chest CT is also can be used as a part of the screening tools, in particular in those patients with extra cardiac sarcoidosis, because pulmonary involvement is seen in 90% of patients in systemic sarcoidosis. Lungs and lymph nodes involvement in 90%. Most frequent abnormalities included enlargement of bilateral mediastinal hilar and axillary lymph nodes, and the chest CT results yield 90% sensitivity and nearly 90% specificity. And also it has an added benefit to localize a lymph node that accessible for biopsy. Echo definitely is a first-line screening test for cardiac sarcoidosis for CS. But the abnormal findings by echocardiography is highly viable. We can see the bilateral ventricular dilatation, reduction in LV, also perhaps in RV, ejection fraction, dilated atrium, and the reduction in spectral tracking imaging in longitudinal strain, and in particular the new technology, the spectral tracking imaging, the longitudinal strain show a promising role in the early diagnosis of CS, or we predict the clinical outcome and perhaps the prognosis. So we could approach two typical echo findings. One is the ventricular septal thinning occurs in the interventricular septal wall, or the posterior lateral bulging, like the aneurysm-like bulging in the posterior lateral wall or in the septum. So it's it's considered to be a highly specific finding in CS diagnosis. However, the frequently observed regional wall motion abnormalities, but we have to bear in mind the other etiology like ischemic cardiomyopathy. Other etiology should be excluded before we give a diagnosis of CS. But the uneven distribution of wall motion abnormality. It's a reflection of scattered granulomas. So those are the two typical echo findings. However, the Korean cardiologists conduct this study 10 years ago, which included over 1,000 patients who received pacemaker or ICD for the brady or tachycardia indication. And they were trying to find the typical echo findings in those patients. Type 1, the marked thinning or akinesia confined to the basal IVS, or type 2, the posterior lateral bulging, aneurysmal bulging, without a history of MI, myocardial infarction. Unfortunately, only a quite small number of patients exhibited suggestive findings, 21 out of 1,357. And among these 21 patients, only 3 showed histologically confirmable sarcoidosis, and the endomyocardial biopsy in 6 patients all failed to demonstrate the CS. So the conclusion of their study, they said that considering the very low yield of the endomyocardial biopsy and the rare extracardial manifestation in CS, the typical echo findings could be an adjunctive diagnostic criteria. But we thought previously, it's a very specific, a highly specific phenomenon in echo on echo. But I would like to have your comment, invaluable comments. You know, I know the panelists. We have echo expert of the in the CMR finding include structural or functional abnormalities, including worsening, aneurysm, chamber dilatation, wall motion abnormality, and bilateral systolic dysfunction. And more importantly, the presence of late ganglion gap enhancement, LGE. And typically, it can appear in a multifocal pattern, mainly involve the basal or mid septum of the LV. Although it can also affect the endocardium, but it's mainly it appear in the subepicardial or midcardium rather than the subendocardium. PET-CT, the FDG PET-CT can distinguish normal tissues from those sites, granuloma formation site, the active inflammation present in the sarcoid granulomatous with a high metabolic or energy demanding. So actually there are 4 categories of imaging findings. The modality include perfusion imaging and metabolism, and the metabolism imaging of FDG. So we're trying to look for the mismatch of the perfusion defect and increased or a higher the tracer uptake of the metabolism imaging. So actually they are normal, early disease, progressive disease, and fibrous disease, which is a very late stage, even with severe perfusion defect, but no FDG uptake. A PET-CT actually is more sensitive than CMR LGE findings. It yields a good diagnostic accuracy for very high sensitivity and a fair specificity. May be useful, as it's very sensitive, it may be useful to rule out the condition of CS. And it's expected to be used in assessment of disease severity and prognosis, as well as disease staging, and also assessment of indication or efficacy of immunosuppressive treatment, detecting flare-ups And later I will talk about the follow-up schedule regimen after the immunosuppressive treatment. Now, we also can use the hybrid use of CMR and PET-CT to have a more sensitive detection of CS at a more early stage. Though the proposed suspicious patterns of CMR of FDG PET, and in this study that the fusion imaging of CMR and PET-CT actually reclassified the diagnosis in about 5%, 50% of patients. Most of them, 80% of them actually are corrected, reclassified. So a fusion imaging of CMR and FDG PET-CT is advocated in the early diagnosis of CS. Endomyocardial biopsy, EMB, is actually the gold standard for the diagnosis, either recommended in those impossible to obtain histological confirmation in other organs. But the no sensitivity is a major drawback of EMB due to the patchy, scattered location of the granulomas of the epicardial, not the endocardial, but subepicardial layers. However, the sensitivity of EMB increases with the number of samples, but also the procedure risk increased. And the investigators also attempted the EP mapping or the imaging guided procedures, such as the CMR or PET imaging guided, trying to increase the sensitivity of the biopsy. Here, the table shows the comparison of the sensitivity, specificity between different parameters, including clinical parameters, ECG, echo imaging, LGE in CMR, and PET-CT. From here, we could see that actually CMR is the most valuable imaging tool to give a diagnosis of CS. And here, the clinical role or limitation of the imaging tools, echo, CMR, PET-CT are listed here. That the echo has a limited sensitivity and specificity. Even we have seen the typical echo findings of the ventricular septal bulging or basolateral aneurysmal bulging. The CMR, there was no, may be less specific for CS. There was no generalized pattern with CS, but the patchy location and many involved the subepicardial or mid myocardial might be a very important clue to the diagnosis. And PET-CT actually increases the sensitivity or insensitivity for the diagnosis of CS, but they need a very good patient preparation for the adequate glucose suppression, like the patient need before several days before the examination, the patient need to have a high-fat, low glucose diet, a bit of the exercise, avoid of long fasting like this, have a good preparation for the examination. So when and who we need to suspect the cardiac sarcoidosis, they are divided into two categories of patients who with known history of extracardiac sarcoidosis and who has no prior history of extracardiac sarcoidosis. Many palpitations, syncope, AV block, LV dysfunction, or the thinning of LV wall of the septum or LV wall abnormalities on echo screening. So how to diagnose CS? There are actually 3 expert consensus or guidelines on the diagnosis and management of CS, including the WASOG, the HRS, and the Japanese Circulation Society. There are actually 2 pathways or 2 ways to diagnosis. The demonstration of histological non-caseating granulomas in myocardial tissue, that's very confirmative. And they're based on the clinical suspicion and cardiac image, many CMR and FDG PET. The guidelines, the WASOG guideline using pathological lab clinical imaging criteria to support a highly probable, at least probable, possible, and no consensus. In a comparison between HRS guideline and Japanese guideline, the HRS guideline, they require histological diagnosis, either in the myocardium or in other organs, extra cardiac other organs. But Japanese Circulation Society, Japanese guideline criteria, the proposed a new concept of isolated cardiac sarcoidosis that they can be diagnosed, the patient can be diagnosed without a histological proof of granuloma formation. But however, they have to fulfill the following major clinical findings, and the PET scan, FDG PET scan is very important in so-called isolated cardiosarcoidosis. And the proposed algorithm for diagnosis would be like this: the patient with clinical suspicious CS and or the patient with extracardiac sarcoidosis, they do echo as a screening tool. And the cardiac MR, if we see the LGE, the patchy LGE, especially in epicardial or mid epicardial, and they could go further for FDG PET, which will increase the sensitivity of diagnosis. But however, there are also many challenges to accurately or timely or early diagnosis of CS, as in the isolated CS, because it's only account for only 5% of patients with confirmed CS. So the so-called isolated CS could be possibly present as the following 3 different ways. All the initial lesions, there was no involvement with other organs, like not involved yet, not infected, because there might be a special type of sarcoidosis that only affecting the heart only, or the not detected, because the inflammation in other organs might be too modest to be detected. And also there are challenges in this way, that there are some similar cardiac syndromes, mimickers of CS, like the ACS, like other inflammatory cardiomyopathies. So the challenges always occurs in the diagnosis, the accurate and timely diagnosis of CS. And the treatment algorithm include the treatment, the etiology treatment, and the treatment of heart failure and high-grade AV block or severe ventricular arrhythmia. For the immunosuppressive therapy, the first line is corticosteroids, or some other steroid-sparing agent like methotrexate. Treatment of heart failure as indicated by the heart failure guideline, the GTMT, from the drug therapy and device therapy, and for the end-stage heart failure, heart transplant. High degree AV block pacing or ICD, we would like to emphasize on this issue. Severe ventricular arrhythmia, ICD, drugs, catheter ablation. And the treatment algorithm, we present it in this flow chart. Myocardial involvement, heart failure, arrhythmia, ECG, Holter, is it ventricular tachycardia, atrial fibrillation, or heart block? Is there any reduction in LV ejection fraction? Different types, phenotypes, different treatment. Immunosuppressive therapy was indicated in those with complete high degree heart block and evidence of myocardial inflammation, and the sustained ventricular arrhythmias or evidence of LV dysfunction and evidence of myocardial inflammation by CMR or increased troponin T, BNP, echo by ventricular dysfunction, and so on. So corticosteroid as the first line, but there were lack of evidence or robust data regarding the RCT or regarding the dose, duration, and the benefit for survival, and so on. And so the expert consider the optimal dose would be an initial dose of 30 to 40 milligrams per day as an empirical regimen, because the optimal dose and how best to assess response keeps unknown. So the monitoring after the treatment, the PET-CT scan every 3 months after stopping treatment to see whether the disease relapse or no relapse. If there's a relapse, we need to restart immunosuppression therapy with corticosteroids or combined with methotrexate MTX. So regarding the very frequent high degree AV block, the treatment comparison between corticosteroid treatment, pacemaker, or ICD. The observational studies find a significant proportion of patients with conduction disturbance recovers after steroid therapy. However, there's still a number of patients, quite percentage of patients, they are not responsive to steroid therapy. In this case, so device therapy, pacemaker or ICD is needed. However, the evidence to support ICD implantation, not just pacemaker in patients with CS has the pacemaker implantation indication. So this study included over 300 patients and 1/3 of them with high degree AV block. In those patients with ejection fraction less than 35% and VT, the 5-year cumulative incidence of sudden death as high as 30%. Even in those patients with a good ejection fraction and no VT, the sudden death, the risk of sudden death is as high as 10%. So that's why implantation of ICD instead of pacemaker should be considered in a patient of CS with pacing indication. So the recommendation listed in guidelines or consensus include this: suspicious, spontaneous sustained ventricular arrhythmia, class 1 indication. So ejection fraction less than 35%, class 1 indication, as in general heart failure patient. But in CS, might be useful, can be useful in patients with an indication of pacemaker, unexplained syncope, inducible sustained ventricular arrhythmia, or it may be considered in patients with a mildly reduced ejection fraction despite optimal medical therapy. And the management of ventricular tachycardia, ventricular arrhythmia, we can use the assessment of ventricular arrhythmia is very important to see if there's any active inflammation. So immunosuppression therapy is can be useful. Antiarrhythmic medication and catheter ablation. So the treatment of heart failure is actually follow the guideline GDMT and GDDT as for those patients with reduced ejection fraction. But in this study, it shows that there might be no improvement in patients with severe LV dysfunction by immunosuppression therapy. So much remains to be learned about the role of corticosteroid improving LV function, dose, duration, the survival benefits. So much remains to be learned. So for the last minutes, I would like to share with you some case series from China. And this case series of 4 CS patients just published in China TBN respirology journal. And all these 4 patients present arrhythmia, cardiac arrhythmia as the initial presentation. And the case 1 is a female, they're all females in 50s, and a complete AV block of frequent ventricular premature beat. And the chest CT finds lymph nodes enlargement and multiple nodules and right lower lung. And but this but the echo and CMR was negative in the first case, but in the second case, and the screening echo test yield LV reduction in LV ejection fraction of 30% and warm margin abnormality inferior, posterior, and lateral. But the coronary angiogram was normal. The PET-CD, resulted in a higher tracer uptake in cervical pump, number pump, and the lymph nodes, mediastinum lymph nodes. So the treatment, DDD, prednisone, MTX, prednisone, and MTX, and all remission in chest CT, no adverse event. And similarly, and the case 3 and case 4 is also a female patient in 50s, and the case 3 is a male patient, and frequent palpitation, and AV block and ventricular tachy, and the chest CT find diffuse nodules in both lungs and enlarged lymph nodes in the mediastinum. And the echo negative, very mild change, 55% ejection fraction, warm motion abnormality, CMR negative or small patchy LGE in subendocardial areas, but the ischemic heart was excluded. Remission after all remission after immunoimpressive and decreased burden of ventricular premature beat and ventricular tachy, no adverse event. And also there's a case report from Hong Kong, 49-year-old Indian woman admitted with shortness of breath, complete AV block, with preserved ejection fraction, no warm motion abnormality at the first hospitalization. So a DDD pacemaker was implanted. However, 3 months later, the patient was detected to have a non-sustained VP that causes pre-syncope. The echo resulted in impaired ejection fraction of 40%. A PET revealed diffused increased tracer uptake in the IVS and RV, multiple lymph nodes at the bilateral healer, and histology of lymph nodes in confirmed the non-necrotizing granuloma formation. So the diagnosis was sarcoidosis with cardiac involvement. The MR finding and PET MR finding and the negative, it really depends on the stage of the diseases of the disease. And the final case was a case from our center, and 35-year-old male was admitted due to palpitation and dyspnea for 7 days. So the lab test, normal liver, renal, and thyroid function injury, there was normal myocardial injury markers. So during admission, the ventricular tachy was recorded. So the TE reviewed the normal chamber size by normal biventricular function, slightly increased LV wall thickness, and thickened, in particular, thickened papillary muscles, and the chest CD revealed diffuse nodules in both lungs with enlarged mediastinum and hilar lymph nodes, bilateral bronchial stenosis as shown in here. A PET CD showed high tracer uptake, and the CMR reviewed LV septoposterior inferior basal LGE. Mainly involved the subapical and mid-myocardial layers. The cervical lymph node biopsy confirmed the granulomatous inflammation. However, the biopsy, the endomyocardial biopsy was negative. So the patient was treated with prednisone 50 milligrams per day for 2 weeks, and gradually decreased the dose approximately, I think, 5 milligrams per 2 weeks, according to the chest CT. And after 22 months later, the prednisone was withdrawn with this chest CT remission. However, 6 months after prednisone withdrawal, he was hospitalized for aggravated palpitation. Also, the LV ejection fraction was preserved. However, the IVS, the increased thickness in IVS was regressed, but the LV size was enlarged from 40 to 52. The still sustained remission by chest CT scan, but the LGE by CMR was actually extended a bit. The Harder shows VT, several rounds of VT and R on T. So the electro EP study reviewed near his-bundle VPB and VT treatment. We give ablation of VPB and VT. However, the patient denied the suggestion of ICD implantation. The symptom relieved. However, we have a question: should the impressive therapy be reinitiated in this patient? So, ladies and gentlemen, this is the conclusion of my talk, and the take-home message. CS is rare, but it might not as rare as reported as we thought. It's a multi-system inflammatory granulomatous disease, so it needs MDT approach. We suspect in those patients with extracardiac sarcoidosis, unexplained palpitation, syncope, arrhythmia, heart failure. So diagnose depends on clinical imaging and histological information. Treatment, immunosuppression at the first line, and device GDMT for heart failure. Monitor, we need multimodality imaging for the follow-up monitoring. Thank you. Thank you for the attention.
Thank you so much, Prof. King Zhang, for your excellent and great presentation. I'm pretty sure we all learned a lot from your presentations today. It's a very comprehensive presentations. And I'm pretty sure there's also many questions from the audience, but at first I would like to ask the opinion from one of the panelists in here, Dr. Siti Elkananauli. Do you want to add any opinion about cardiac sarcoidosis, especially related to the echocardiography findings, Dr. Nauli?
Assalamualaikum. Thank you, Dr. Sasmaya and Prof. Singh. It is interesting that regarding the diagnostic and also therapeutic area of cardiac sarcoidosis is not that simple, because most of our patient comes from other division who unfortunately we did cardiac echocardiography. So unfortunately, we found some clues regarding the thinning of basal interventricular septum. But you know that sensitivity and also especially in echocardiography is very low in diagnosis, especially early signs of cardiac sarcoidosis. So it is not easy for us to conclude is there regarding the use of echocardiography in early stage of cardiac sarcoidosis. But most from the journal and also article, we found that echocardiography is mostly useful in terms of prognosis, and also relapse of the cardiac sarcoidosis. Yes, we can use such as global longitudinal strain, and also like your case before, the septal going thick again. But in this staging, in very early stage, do you have any clue regarding the use of any tools in cardiac sarcoidosis?
Okay, thank you so much, Dr. Nauli, for your opinion about echocardiography. And there are many questions actually, Prof. King. I'm pretty sure because this is a very interesting topic to be discussed. And I saw from the audience, there are one audience, Dr. Lucia Chris Diana, that raised hand. Probably you want to ask directly to Prof. King. I already put you as an allow to talk. Dr. Chris, do you want to ask directly to Prof. King or? Okay, probably later on. Okay, probably later on. Okay, there's many questions in here, but before we go to the questions from the audience, probably I would like to ask Dr. Yasmin. Dr. Yasmin here is an expert in cardiac imaging, Prof. King. She is also a staff in our department. So, Dr. Yasmin, I would like to. Do you want to deliver some questions to Prof. King instead
Yes,
of add-ons? Okay.
Actually, I'm not that expert. I'm a newbie in imaging studies. Prof. King, nice to meet you virtually. I would like to ask for your take on combining the PET and MR. Is it very necessary for us to combine those both modalities in terms of evaluating cardiac sarcoidosis and its progressive towards the disease or disease activity? What's your take on it, Prof. King? Thank you.
Thank you for the comments. So due to the very limited experience of my own, so that might be the only CS case that I diagnosed. So I actually did a profound literature review, tried to learn from the others. And I know that the American colleagues, that they have a quite good experience of treating and diagnosing and treating CS. And I think a few years ago, I visited UPenn, University of Pennsylvania. I just stayed there for 2 days. I saw 3 cases of CS. So there might be more cases, or that the CS case is actually underdiagnosed diagnosis by us. You know, We are
A long way to go.
I think actually we overlooked the clinical presentation, like the complete AV block, because from the literature and the guideline, they say we should look for those patients with unexplained AV block, in particular in young patients. But how do you explain or understand the terms unexplained? So what is unexplained? I think the different doctors have their different understanding on that. But that would give us a clue to look for CS in those patients.
Sure. Okay, thank you so much. So basically, there's one question from the audience related to the diagnosis first. So there are one questions regarding, let's say, if we have patients that we are suspected as cardiac sarcoidosis, we suspect this patient as cardiac sarcoidosis, and then we do multimodality imaging, let's say MRI, CMRI, and then also echo, but because of limited limited availability in terms of PET scan, we usually skip the PET scan, and then we usually go to the endomyocardial biopsy. But as what you presented before, that endomyocardial biopsy usually will turns out negative findings. So in this group of patients, should we continue the imaging into PET scan, because we are highly suspected these patients as a cardiac sarcoidosis, although the endomyocardial biopsy said negative findings? So what is your opinion in here in terms of our effort to diagnose cardiac sarcoidosis? Thank you so much.
Either if it's isolated cardiac sarcoidosis, then you should go further for PET scan.
Yep.
As the EMB biopsy yield very low sensitivity. But however, I think due to the very low sensitivity, the negative biopsy cannot exclude cardiac sarcoidosis, unlike the amyloidosis.
Yes.
Amyloidosis. Unlike that, so the negative biopsy cannot exclude. But if it's cardiac involvement or CS with the extra cardiac sarcoidosis, we try to get the biopsy and the histologic confirmation from the other organs. I think both way.
Okay, sure, because it's very important. I think this is a very important message. Usually we tend to do like, okay, endomyocardial biopsy is a gold standard to diagnose cardiac sarcoidosis. Yes, indeed. But sometimes it's very difficult for us to reach or to get the myocyte or we can, it's very difficult for us to get the non-cessating granulomatous in cardiac sarcoidosis, considering that it's a patchy lesion. So in our center, we also only have one patient that is confirmed based on endomyocardial biopsy. The rest is only based on multimodality imaging. So yes, indeed, it is very important for us to do multimodality imaging in patients with highly suspected cardiac sarcoidosis. And then also regarding, there's one question about, in your center, do you use 18 FDG PET scan, or can you use another tracer to diagnose cardiac sarcoidosis, such as DOTA-TATE or something like that? Do you, in your center, use, what kind of tracer do you use in your center?
We use FDG tracer, but I'm not sure about other kind of tracers. Okay. We use FDG. Sure. Yeah.
Okay, thank you so much. And then we move to the diagnosis, and then we move to the treatment. There's a few questions in here, and one is the very interesting questions is regarding immunosuppressive treatment. So the questions will be, we know that we need to give immunosuppressant treatment for patients that is confirmed as a cardiac sarcoidosis, especially in the active state of cardiac sarcoidosis. We need to give immunosuppressant. And then the first choice usually is glucocorticoid or prednisolone or prednisone. The questions from the audience and also my own questions actually, I also a bit curious, because from your case presentations, you gave both immunosuppressants. So you gave steroid, and then you also gave these patients MMF, and the other patients you gave methotrexate. So will you give prednisone first, or you directly will give both combinations of immunosuppressant in patients with cardiac sarcoidosis? Prof. Qing.
I myself, I don't have such an experience, but according to the experience of Mayo Clinic doctors, they actually they use both prednisone, corticosteroids, and the MTX. The reason for that is try to lower the dose of the steroid by with the add-on MTX. Yeah. But we don't have such an experience, you know, in our center.
Okay, so in your center, you usually will give prednisone first, and then after that, you try to evaluate?
Yes,
yeah,
that's true.
Okay.
Yeah.
We also do the same thing in our center. Okay.
And we also would consult our rheumatologist because these systematic inflammation. So whether to add on MTX, we would like to consult our rheumatologist. So it's usually an MDT approach.
Okay. And will you give, and then there's another questions in here. Will you give for a long term, for long life, for the prednisone or whatever the immunosuppressant, or you will try to evaluate if there's no active inflammations again, then you will just stop the immunosuppressant and then you do monitoring regularly, something like that, or you just give long life?
Actually, there's no answer yet. So in the cases I presented, those from Beijing, Hong Kong, and our center, is actually the duration of steroid therapies actually depends on the remission of chest CT. So actually we stopped the because we in our case we stopped the steroid therapy after 22 months. But in other cases they just treat the patient 3 months, 6 months, depends on the chest CT. But I also looked some cases from Mayo Clinic. They said their total duration of steroid therapy might be 6 months around.
Okay, thank you so much, Prof. Qing. Dr. Nolly or Dr. Yasmin, any other opinion or questions?
Yes, I would like to ask more question, Dr. Qing. What do you think if we don't have any PET scan available in our settings? Is it quite reasonable for us to evaluate the inflammation with using a T2-weighted imaging, such as in terms of CMR evaluation? Do you think it's enough? Yes,
the T2-weighted imaging is actually added now in the guideline, actually in the expert consensus guideline. It's very useful. It's very useful. Yeah.
Okay. Dr. Nolly, any comment or questions?
No, Dr. Hawani, I think it's already clear.
Okay, thank you so much. And then the last questions, you may answer briefly, Prof. Qing, due to the limited time. There's one question from our colleague, actually from the EP side. He asked about, let's say if the patients have AV block and then